This is another view which is showing this well-capsulated lesion crossing distal and subproximal interphalangeal joints. Well, the lesion has a typical hyperechoic appearance akin to a few of the uh, common pathologies we find at other subcutaneous species, lipoma. And this is the transverse section showing the relation of tumor with flexor tendons. The lesion was avascular, and on dynamic study, we could see as he was having difficulty in flexing the finger. We can see that there is compression by lesion tumor, and flexor tendons are finding it difficult to do checksum, but one can see it. So on the complaints and sonography appearance, we suspected this should be lipoma, and patient was posted for surgery. And in surgery, a solid lesion was there, and histopathology came out to be lipoma. Now, few points to discuss. To reach any of our diagnosis, we require age, clinical presentation, and histopathology decides the sonography and imaging findings. So, in present study, most of the finger tumors are mesodermal in origin. They arise from muscle, tendon, synovial skin, like that. And hand tumors, they account for 15% of the whole body soft tissue tumors, and out of them 95% without skin involvement are benign. They present early as they have superficial location, and thus mostly good prognosis. Malignancy is less likely. Common finger or wrist tumors are ganglion is the commonest, which is almost cystic, and size is usually smaller than what we find in our case. Lipoma is the commonest solid or soft tissue tumor. Tenosynovial giant cell tumor is another common entity that is also painless. The sonography appearance was favoring lipoma, otherwise we would have thought of giant cell tumor also. Other less common are fibroma, vascular malformation, peripheral nerve tumors, glomas, synovial sarcoma, etc. This is the second case. 50-year male patient had distal radial fracture year back, and suddenly he presented with cessation of thumb movement. A lateral radiograph is showing old united fracture, distal and radius, with plate and screws. They are coming out of the cortex. And on clinical examination, he had the normal side had thumb movement. This is a abnormal side where he had a difficulty in extension. I'm sorry for some poor video quality because it is some old case. Now we suspected that since there was no extension of thumb, extensor pollicis longus tendon may be a reason, and we did ultrasound. On ultrasound, we found that there was pair of extensor pollicis longus tendon with retracted proximal and distal ends. One can see edematous proximal and distal ends with no tendon in between. The screws were seen. They are coming out of the radial cortex and impinging over extensor tendons. The asymptomatic side is having compartment 3 tendon, EPL in situ, while the symptomatic side had no such tendon with fluid inside, and that is an empty sleeve. Now this is a video showing screw tracks. Compartment 3 tendon is being impinged by screws, fluid in the EPL tendon sleeve with retraction of muscular tendinous junction or retraction of the proximal end of EPL tendon proximally, that one can see. The another still image is showing the EPL makes distal intersection with compartment 2 tendons, and that EPL sleeve is also empty. Distal intersection EPL sleeve is empty. This is another image showing screw tracks with proximal and distal retracted ends, empty compartment 3 tendon on transverse section, and surgeon wanted to know status of palmaris longus tendon because many a times it is a clinical diagnosis whether palmaris longus tendon is there or not, but sometimes in a thick or obese person or some difficulty or maybe congenitally absent in few cases, the request was there and we could find palmaris longus tendon at its place. So this is another video showing retracted distal end of EPL tendon. With pressing proximally, one can see compartment 2 tendon, but compartment 3 tendon is not there with fluid replacing it. Screw tracks are there and retracted proximal end. Now, since the surgery was planned, this is a palmaris longus tendon was there, which was harvested. Now, this is another panoramic view showing retracted proximal and distal ends of EPL tendon. On surgery, the diagnosis was confirmed with retracted distal EPL end is there. These are few surgical videos which confirmed our diagnosis, and palmaris longus tendon was also harvested, and finally they could suture with thumb in extension. That was the final result. This is another patient for illustrative purpose in same surgery, and the last image showing reconstructed EPL tendon with thumb in extension. For discussion purpose, this is a normal video showing compartment 2 and compartment 3 tendons with listus tubercle in between. In longitudinal and transverse section, we can see. So EPL tendon tear. EPL is a muscle whose tendon follows a complex anatomical course in the hand to allow thumb extension, and it is primary extensions of the thumb's terminal phalanx. Almost all manual activities require use of EPL. Therefore, when it is ruptured, it can be very disabling for the patients. Delayed EPL tendon rupture is a known complication associated with distal radial fractures, common in adults. Now, traumatic and spontaneous, these are the two causes of EPL rupture. Among traumatic, one is spontaneous. Among traumatic, direct cuts to the tendon or lacerations are found, and distal undisplaced, undisplaced or minimally displaced distal radial fractures are the commonest culprits. The comminuted and displaced fractures are showing less association of EPL tear, delayed EPL tear, but undisplaced or minimally displaced distal radial fractures are the commonest causes. And among spontaneous rupture, rheumatoid arthritis, systemic or local steroids, repetitive wrist motions, tenosynovitis, carpometacarpal osteoarthritis, these are the causes for EPL rupture. And delayed EPL rupture is known among fracture cases. Two peaks are there. One is 5 to 8 weeks after trauma, and other is 3 to 12 months. While traumatic soft tissue related EPL rupture following direct cuts or lacerations, it is usually found immediately or within a week's time. Now, what is the reason why EPL ruptures commonly over other tendons? There is a watershed area around the listus tubercle, and EPL lacks a mesotendon there. So visceral tendency is insufficiently vascularized, and following fracture, hematomas, fracture callus, they lead to EPL compartment narrowing that entrap the tendon, which causes ischemia, and after ischemia, avascular necrosis and rupture of EPL tendon takes place. As well, in a mechanical fracture line with locally ischemic tendon, that weakens the tendon, and they may lead to late rupture the listus tubercle. So we find that whenever the degree of fracture displacement is less, there is more likelihood of EPL tendon rupture. Distal radial fracture is the most common causes. Other are lacerations, blunt trauma, direct cuts. This is the third case. Nidhi madam inspired to post this case. Previously, I was to include some other case, but I thought that they should be included. This is a 45-year female who had a painless swelling at the distal phalanges of index fingers, both, and sent by dermatologist to roll out epidermoid. And she had malaise and body ache and few non-specific constitutional symptoms since last 2-3 weeks. So she, the physician advised few common blood tests. Among that, ANA was weakly positive. So she came for ultrasound. No other significant medical history was there. On high resolution sonography, one can find fluid collection in subcutaneous plane in the distal phalanges just proximal to the nail bed. Fluid collection is connecting with distal interphalangeal joint. some irregular joint, some irregular and newborn formation and bone cortical irregularity is seen around the distal interphalangeal joint. Fluid is seen around extensor digitorum tendon as well. So this image is showing newborn formation, enthesitis, and pathology around distal interphalangeal joint. This is a video which is depicting fluid collection in subcutaneous plane in relation to extensor digitorum tendon. Fluid is also seen around extensor digitorum tendon with some irregular newborn formation around DIP joint. I'm sorry, this transverse section video is not playing. This is another image. As the disease, as the swelling around the distal phalanx was there on both the sides. Left was having larger swelling, the right was having smaller swelling. So that can be found and flowed around the extensor digitorum tendon, and bony irregularity around distal interphalangeal joint is there. Here also the same findings are there. They are seen slightly more clear because of the larger image size. Now other fingers also scanned, though there were no swelling over distal phalanges, but tendons, extensor digitorum tendons were showing fluid collection, newborn formation, enthesitis, and similar findings as the index fingers were there. So maybe around 5-6 joints are involved. This is a normal subject who had no problem, and there is no fluid collection, no pathology involving distal interphalangeal joint. The radiograph was advised because there were no medical history, no known arthritis, nothing were there, and these findings were there. That's why we did X-ray hand, as it was a polyarticular movement standard X-rays. Both hands and wrists were advised, and around 4 to 5 or 6 distal interphalangeal joints were involved. On lateral radiographs, one can see some amount of periostitis or newborn formation also there. So we suspected that clinical findings, sonography and radiographic findings, we suspected that this is some spondyloarthritis, some maybe seropositive or seronegative. But looking at history and other things, we suspected this is a psoriatic arthropathy. And other less likely possibility of rheumatoid or other inflammatory arthritis were suspected. Now for discussion purpose, it is polyarthritis because it is involving more than 5 joints. Common causes of polyarthritis are commonest are autoimmune, rheumatoid is the commonest. The others are psoriatic, SLE, crystal arthropathy. Tuberculosis is one of the common causes. Malignancy and other medical conditions are there. So to reach a diagnosis for such pathology, we require complete medical history, physical examination, simple lab findings like CBC, ESR, and other RA factor, anti-CCP, anti-nuclear antibodies, and other tests are required as required. In psoriatic arthropathy, there is no single definitive laboratory test. It is a combination of blood test and ruling out other conditions, and there are always some overlaps, or arthritis may be non-specific, or there are many differences. And dermatological features of psoriasis precede arthritis in 60 to more than 60% cases, and arthritic features are seen predominantly before dermatological features in less number of cases. There is a strong association of nail involvement with distal interphalangeal joint arthritis. Initially, any polyarthritis may start as asymmetrical oligoarthritis with spondylitis or SI joint involvement. It may ultimately progress to polyarthritis in due courses. In particularly psoriatic arthropathies, larger joints like knees, elbows, ankles, shoulders are less frequently involved. And many of them, they have actually B27 positive, and few even have RA factor positive. And they have extra-articular manifestations, ocular, gastrointestinal tract, cardiac, urogenital system are other commonly involved. So hallmark of psoriatic arthropathy is erosions, newborn formation, newborn proliferation, and it has a distal distribution. distal interphalangeal joints, then proximal, then metacarpophalangeal joints. And hands are more commonly involved than feet. Early imaging or X-ray findings are enthesitis, marginal bone erosions, bone proliferation, irregular fuzzy appearance of bone, new bone formation, periostitis, periosteal layer of new bone or irregular cortical thickening, dactylitis, sausage digit. The whole of the finger is swollen and sonography shows underlying synovitis and tenosynovitis, asymmetrical sacroiliitis, asymmetric paravertebral ossification, sparing the facet joints are early radiographic findings. And lately, uh, these are means they psoriatic can lead to these blood complications, rheumatoid, any long-term polyarthritis have nearly similar neuropathic joint may also have the same appearance that joint subluxation, interphalangeal joint ankylosis, acrosteolysis, telescoping of fingers like that. To summarize, this is the last slide of psoriatic. Ultrasound is complementary to clinical examination by adding sites of disease, which joints are involved, that one can see. And there are many times discordance, joint pain and ultrasound findings, or ultrasound and clinical, they may not correlate exactly because this type of variability we usually find in many of the polyarthritis. As we have composite sonography scoring in rheumatoid, that scoring we may apply, but it is not very helpful at present. So it is a research tool, and we hope that in future sonography becomes widely accepted for disease monitoring purpose. If the time is there, one small case is there. Dr. Ankit?
Yeah, please go ahead. Please go ahead.
Yeah.
Maybe another 5
This
minutes.
is
Yes.
Yeah, thank you. This is a small case. A 16-year lady who had a glass injury, index finger 2 years ago, and she was continuing with sometimes some glass particles, they were coming out, but it was not very limiting her activity, so she was continuing. She came for repeated pancreatic sonographies and then requested me to see whether something is there or not. On ultrasound, we find that foreign body is there. Since it was there since quite a long time, some chronic inflammatory changes were there. Foreign body granuloma was found, and on dynamic you can see the relation. So here also sonography was helpful and it was removed. And glass foreign bodies, wood splinters, metal pins, wire, jerry are the common causes of hand foreign bodies, and crushed injuries are also common findings. I'm thankful to these doctors who sent me cases or provided me operative images. Thanks to MUS and the teachers for giving me opportunity.